It works. Nope. Restart it. All right, I guess we're going off that. Y'all can see that okay? All right, so what is a mood disorder? The DSM kind of puts it in a big umbrella term, okay? It's one that encompasses a bunch of different conditions that we're going to go over today. It's extreme swings in mood or extreme lows, extreme highs in mood. Mood is not something that's extremely hard to define either. It's exactly what you think it is. It's emotion regulations, okay? These extreme highs, these extreme lows, you know, they both have impacts on occupational performance, daily life, pretty much all over the place. Does anybody know what the disorder is that you have extreme highs and extreme lows? Bipolar. We're going to go over bipolar today. Most of these disorders that we are talking about, you've probably heard or have known somebody who's gone through something like this or had one of these disorders. They're one of the most common things that we're going to talk about today. That's why I think it's so beneficial. We're going to do a little intervention discussion about what you can do to help somebody that's going through these kind of disorders. Okay? All right, so let's talk about some DSM criteria. You're going to want to write down some notes from this, okay? You have episodes that help define what a disorder is, okay? You have depressive episodes. This is the increase or decrease in sleep, weight gain or loss, difficulty concentrating, a feeling of worthlessness or feeling of guilt. They're gonna have abnormally elevated mood or irritable mood for at least 1 week. And that's going to happen in conjunction or comorbidly with some of those other symptoms I just talked about.
So they need to have one of these episodes to get a mood?
No. Well, I'm going to tell you that criteria in just a minute. Each one has a little bit different criteria of what makes it fit in, because then there's breakdowns of depression, then there's breakdowns of bipolar, there's different subcategories, and each one has its own specific criteria, okay? And I have some really good videos here too that break it down really, really good for you guys, okay?
What does this slide fall under?
What do you mean? This is just an overview. So these episodes are what make up the disorders. It'll say like this many depressive episodes will make up this diagnosis. Make sense? That's what the episodes are for. It's episodes are themselves not the disorder. It's what makes up the disorder. Like bipolar is depressive and manic episodes. You know, it's both and swinging back and forth. Got me? Okay, so any questions on what a depressive episode looks like? Okay, a manic episode is an inflated self-esteem, a decreased need for sleep, rapid speech, psychomotor agitation, not being able to really sit still, and often involvement in high-risk activities. And that can be, you know, something subtle that may actually be seen as a normal activity to people who don't know the person. Like, for example, a big high-risk activity goes spending all of your paycheck on a big shopping spree knowing that you have bills at home, okay? That might seem normal, like people around might not see this person as having a manic episode, but people close to them know, like, you really don't have the money to do that. This is a behavior that's not okay. Okay. All right, then you have a hypomanic episode. It's very similar to a manic episode, but it's a lower intensity, hypo. So same as we would say hypo, same terminology there. Hypomanic is same as manic, but less intense. There's not going to be a real influence on occupational functioning and daily life with a hypomanic episode. Okay? We good? We'll start talking about some of the disorders now, okay? So you have depressive disorder. There's different subcategories that we're going to go into, but overall, you need to have at least 5 signs that we're going to talk about here in just a second within 2 weeks. This is where one or more instance of major depressive episode, or one of those depressive episodes we talked about, but you have no occurrence of a manic episode. Okay, there is no swing back to the intense, happy, inflated self-esteem. There's no swing back. Often is considered or named unipolar depressive disorder. Maybe think of it as major depression, things like that. One interesting statistic I wanted to mention to you guys is estimated about 15% of people who have depression, depressive disorder, will die by suicide. I think it's a really astronomically high number, and it's scary. That's why early intervention, we're going to talk about this too, is early intervention is key to helping subside that risk factor. Depressive disorder is with those different signs and stuff with the depressive episode. Each person is going to be different in their severity. Some people may have a crippling type of depression. Some, they can hide it better than others. Some, you're going to see it. These people are more likely to experience a physical illness, either by stress on the body or whatever factor from these episodes. It may get so severe that psychosis can even be present. Some other characteristics here are melancholic, melancholic. What this is a loss of pleasure in pretty much every activity. Even when something good happens, there's really no pleasure or mood swing back to being happy. They probably wake up early in the morning, but they don't feel rested. They may even have a sense of increased depression in the morning, even after sleeping, because they didn't sleep well, or they just have this crippling sense of depression over them. This one's marked by weight loss and the psychomotor agitation. This, is a factor in why they wake up early. Restlessness. Then you have atypical. That is the opposite of melancholic, meaning that if something good happens, they do feel good about it, right? The one defining factor here is that a person with atypical could actually feel a sense of paralysis, literally like there's just so much weight on them, they can't move. That's a lot of people with atypical depression will report that they have this sense like they're paralyzed. They don't know what to do. They can't move. And lastly is the peripartum onset or post-pregnancy onset. That can be due to a whole bunch of different factors. You guys can look up. There's videos of women talking about post-pregnancy depression and, feeling a disconnect with the baby and stuff. There's a lot of things that's interesting. I couldn't find one myself. I didn't have time to look for one this morning, but, it's interesting to read about. I got a couple more to go over. Sorry. Persistent depressive disorder is very similar to major depressive disorder, but it has less severe symptoms and it's considered more chronic, meaning it will go more than 2 years. More than 2 years might be important. Okay. Then you have bipolar disorder. This is the one I was talking about where it goes back and forth in between really high highs, really low lows. Bipolar 1 is the first subcategory of that. Bipolar 1 is one or more manic episodes or mixed episodes like mood changes. So when you think of manic episodes and bipolar, that is bipolar 1. Yep. Bipolar 1 is one or more manic episode or mixed episodes. Okay. Bipolar 2 is one or more major depressive episodes and at least one hypomanic episode. Again, hypomanic episodes might be more troubling to the family or people that really know the person, but not be noticed by the person actually experienced it. They can be very mild, but to the person, because there's not a real impact on occupational performance. With bipolar 1, though, that's more of the long-term impact on occupational performance. Okay? Last one under that is cyclothymic disorder. CYCLOTHYMIC. Okay, this is like a sudden mood change kind of thing. It's chronic, has to be at least for 2 years, but this is fluctuating between hypomanic and depressive symptoms. So it's not going really high highs and really low lows. It's kind of going back and forth. If you think of it as a stable mood in the middle, they're going to just barely be on one side of the fence and barely on the other and fluctuate back and forth. Okay? You got me? Does that make sense? Okay. So cyclothymic is these sudden mood changes. Okay? All right. So what's the cause? What do you guys think? What is the cause? Chemical imbalances. There's a lot of things that can do this. That's why I broke it down into some more categories here. So some neurobiological factors. These are the things that are most associated with depression. People think about depression and mood disorders because most of the time these people are going to have medication for these disorders. And this is what it's trying to fight against is these neurobiological factors. Just a little thing as far as brain makeup goes is there's decreased neurotransmitters for depression, more neurotransmitters for mania. It could be, developing a mood disorder could be your body's response to some kind of extreme stressful event or an extreme type of stress. And another cause could actually be like different cardiac rhythms, sleep disturbances. It's not a symptom of a mood disorder. That could be a cause of a mood disorder. Some environmental things can be, life stressors, violence, abuse. Childhood trauma seems to be a strong link. Very well could be a factor of like the mother infants that have a depressed mother are more likely to get it. There's a lot of statistics that go that way. Could be a genetic link. Last is cognitive styles. That's an interesting one. What do you think that means? Cognitive meaning what? Thinking. Okay, so thinking styles. How could someone's thinking style develop or help or assist in developing a mood disorder?
Like a glass half full.
Exactly. It's the way you talk to yourself, the way you explain certain situations or stressful events or whatever to yourself. For example, you're in a lunchroom or something, you spill coffee or a drink on you and people laugh at you. And you're going to convince yourself now you're going to be the laughing stock of the school. Everybody's going to be like, you're just putting this more stress on you in the way you're explaining the situation to yourself, the way you're reasoning. That's what it means by cognitive styles. To me, and this is just a personal opinion of it, I think that has one of the strongest effects in developing a mood disorder is how you're talking to yourself through situations, right? And then once a mood disorder or one of these episodes is happening, that only escalates that, right? You're talking yourself through it in both ways. Something happens and you talk yourself completely out of it. Like I mentioned, the whole spending all of your bill money on a shopping spree, and then the opposite of that, oh, I can't spend anything at all because I'm going to be bankrupt and homeless, and, talking yourself through situations in a really negative way. As far as prevalence goes, depression is pretty high. It's about 7% of adult men and 12% of adult women. I think that number is going to continue to go up as more and more people are asking. It could be very more prevalent in women because women are more likely to seek help than men. Men will manifest depression in anger and those kind of moods rather than, seeking help. One interesting part here is bipolar disorder is being diagnosed much more in adolescents and in children than what it used to. It's a 40-fold difference, 40 times more if youth is in an outpatient setting. So, seeking psychiatric help outside of a facility, and a 4-fold increase in inpatient. Why do you think it's gone so high?
Do they have to give them that diagnosis? Give them certain medication?
That's an interesting point. I don't know. That would be, you guys have asked some really good questions in this course. That would be some questions to ask Dr. O'Keefe when he's here.
I had a 9-year-old diagnosed with bipolar.
Right.
Did they do that to get her?
It very well could be. We're going to talk about medications because this is one of the disorders, or these disorders are commonly treated with medication. Most of them we've talked about, I'm like, there's not really a good medication. That's not the case with mood disorders. Mood disorders are commonly treated and are very successful with medication treatment. That's why most people buy into the neurobiological factor of it, and that it can be treated with medications. Now, there's other treatments and things we're going to talk about that you may or may not have heard before, like ECTs and light therapies and stuff that are very effective as well when medication doesn't work.
Oh, the rapid eye movement.
Yeah, the REM. What does REM sleep have to do with it?
It's a therapy they're starting to do.
Oh, yeah? Interesting. I'd like to know what it is. I mean, REM is just rapid eye movement for sleep, but that just means a deep sleep. Maybe that's what they're saying, that increased sleep may help.
Am I right?
Okay. Well, we'll look it up, or I'll look it up later. You kind of sparked my interest because I think this stuff is interesting to know about, because this is one of the few psychiatric disorders and stuff that we talk about. Like, there's treatments that are working and acceptable, and there's like a standard of it, So the course, the age of onset for major depression is about the mid-20s, but it can occur at any point in the lifespan. There's no real rhyme or reason. It's highly recurrent, meaning that, most people who have one episode or major depressive episode normally go through another. It is considered chronic. It recurs. What area do you think, as far as occupation goes, is the most affected by having a mood disorder? Statistically, anyway. What area of occupation, what area of your life do you think is affected the most by a mood disorder? Hygiene's a big one. Social. Think of an area that all of those come together. Social, hygiene. There's a lot of stuff, but the one I'm getting at is employment. Work is statistically the most affected by someone suffering from a mood disorder because of having to wake up, do the hygiene, not feeling like it's going to, talking yourself out of that, the need to go to work. It's all talking, work is so much like the social, the hygiene, the, task management, all these areas coming together into one placement, right? You can kind of be and do whatever you feel like you need to at home. At work, you kind of have a set of standards you have to make, right? So a lot of our ADLs and IDLs come together into the workplace. They kind of help make successful employment. And that's a big difference here, is not just employment, but it affects successful employment. Okay, you're going to want to know that. It's very important. The age of onset for bipolar is typically before the age of 19. Again, it's been diagnosed more and more common. A lot of the times these are going to be comorbid with other physical illnesses like diabetes or even a stroke, cancer, Parkinson's. Depression can come with all that stuff, or any major illness or injury that, has come and affected your daily occupations, right? So let's talk a little bit about gender differences. Depression is twice as prevalent among females, so roughly twice, not quite twice, but roughly. And then bipolar occurs pretty much even between males and females. There's not a difference between the two on that rate. Okay. So some impact on occupational performance. To me, what isn't it going to affect, right? There's so much that this is going to, if your mood is low or your mood is overly high, that's going to affect every area in your daily life. There's a negative stigma that needs to be addressed too about reaching out for depression, especially with men and feeling like you're weak and asking for help. That stigma is very wrong, and trying to help somebody open up and understand that there's help available to them. Knowing the statistics with suicide and stuff, it's a very dangerous thing you can't just play with, right? Like, this is something that needs to be addressed by a medical professional. The right help needs to be in there, and the right team needs to be around these people. See, even like, think about the stigma with manic episodes and like people going through like, oh, you just did that because that was, that's just so, you're such an irresponsible person. How dare you spend all of your money on, junk food at the mall? Like, all these things going into making the stigma more and more people are less willing to reach out for help. So let's talk about some interventions, okay? These are going to be important medications to know, like I said, because these are the major interventions for mood disorders, okay? I'm probably going to butcher these, so just bear with me, okay? MAOIS, MAOIS, it's capital M, capital A, capital O, capital IS, okay? Monoamine oxidase inhibitors, okay? These are very effective, but they have side effects when treating depression. Another subcategory is tricyclic. Yeah, I think I said that right. Antidepressant. They also have a lot of side effects. Probably the most common that you guys have heard of is the serotonin reuptake inhibitors, SSRIs. Another common one is the neuroepinephrine reuptake inhibitors, SNRIs. That's another really common subcategory. When you think of depression medication treatment, it is SSRIs and SNRIs are the most common. Okay? They have a lot fewer side effects, but some of their side effects suck. They just do. Loss of sex drive is probably the most common, and it's the most common reason people stop taking their medication. That one's the most reported. Insomnia is another one. But normally these kind of side effects, negative side effects, after you stop taking them, it takes them, 4 to 6 weeks ish for you to stop having these symptoms and stuff or side effects from the medication. For bipolar disorder, you're going to want to know this. Lithium carbide is the major treatment for bipolar. It is a mood stabilizer, and they pretty much use that their entire life, lifelong use. It's the gold standard of treatment with bipolar. Lithium carbide. Okay. Another one is anticonvulsants can be used as mood stabilizers, and they'll help reduce like psychotic symptoms if it gets to that point. Some non-medication treatments are electroconvulsive therapy or ECTs. This is where they hook up, and I have a video to show you. They hook up electrodes to their head and cause a mild seizure in their brain. It's kind of like a reset almost, and it helps the brain build neurotransmitters it's mainly used for depression. They probably would not tell you that they use this for manic episodes as much. Mainly depression is it used for. It normally takes a few sessions, 6, 12 sessions. Some people takes a handful, some people takes more, but this is used when medication is not working. And it also assists in medication to start working. So it's not like an end-all be-all, but it assists with helping other treatments work too. Then you have light therapy. It replaces sunlight lost in winter months. It gives off, the vitamins and stuff that you get from the sun. It helps with that. A lot of people say they get depressed in darker seasons, fall into late winter, stuff like that. Okay?
Does that ECT, does it change the chemistry in your brain, or just like the waves of the?
Yeah, it more or less helps. It's like a reset, and he explains it really well in the video too. It's actually a video from WVU. I just found it one day. I was like, hey, I can use that. All right, so this is a video about bipolar disorder.
Living with bipolar illness, I think it makes me a better psychiatrist. When someone comes to me with something, I don't only know it intellectually, I know it through a lived experience. There are times where I can feel that the patient would benefit from maybe knowing that.
Oh, sorry. My bad.
Living with bipolar illness, I think it makes me a better psychiatrist. When someone comes to me with something, I don't only know it intellectually, I know it through a lived experience. There are times where I can feel that the patient would benefit from maybe knowing that I really understand what they're going through. But I think right now, unfortunately, within medicine and even within psychiatry, stigma still does exist. I'm hoping that maybe one day I will be able to be more open about it. Because it does feel like I can't really share a big part of myself that could potentially benefit someone else or give them hope. I had this great life, I was in medical school, I had great friends, I had a great family, and I had a certain vision of what my future was going to be. When I first experienced my first episode, the psychiatrist felt that I needed an antipsychotic medication. And that moment was like, it's almost like the carpet was pulled from under my feet. I kind of saw myself as, like less than and mentally ill. I really felt the stigma. I had a hard time looking people in the eyes and facing friends. people were talking about, oh, when you get better, and I would look at them like, when I get better, what are you talking about? This is how I'm going to be for the rest of my life. I was thinking, I'm never going to return to school. This is never going to get better. And you're also sort of grieving that amazing life that you thought that you were going to have, and all of a sudden it's gone. The first depression that I experienced was very, very severe. I had to take a year off school. I spent most of my time like in bed, and my family had to literally come and like peel me out of bed off the floor. All I could think about was just dying. Every moment was just agony. Like every moment felt like an eternity. Just feeling like I'm hopeless. Like I'm never gonna get better. My life is over. When I kind of lost faith in myself, I had several friends just regularly calling me, and they would just remind me, "We love you. We're here for you. This is who you are." But I was thinking about all these ways that I would end my life. I never attempted. The only thing that kept me alive was I could not hurt my family and my friends. I just couldn't. When I started the recovery process, never in a million years did I think that I was going to come back to school. I never thought that I was going to get married. I didn't think that I would have a family. It was a good year and a half until finally we found the right combination of medications, and until I really fully recovered and started to feel fully like myself. The number one most important thing in my recovery is the people around me. I have a really amazing and supportive husband, really, incredible parents-in-law, a very strong friend network. Everyone knows about, my illness, and they're very open with me. Thankfully, I haven't experienced depression in years, but I definitely do fear it. It's not like at the forefront of my mind, but because of that, I do everything I can to prevent it. I try to keep it in perspective. Okay, it's part of who I am. It doesn't define me. It affects me, but it doesn't define me. Eyes wide open, unafraid to be alive. Feel your breathing. You will make it.
All right.
Depression is a really quiet. At the very
I'm gonna make this a little bigger. Yeah, I can see that. Is that better?
Depression is a really quietly. At the very beginning, you struggle with the little things, but you usually just ignore them. It's like a headache. You'll tell yourself it's temporary and it will pass. It's just another bad day. But it's not. You're stuck in this state of mind. You get used to putting on a social mask, and you continue to live among other people because it's what you have to do. That's what others do. However, the problem does not go away. You struggle to put on a play every day, and it starts to cost you more and more. That is where you fall even deeper, and that's when you slowly start to back away from friends and family, sometimes completely shutting them out. more satisfaction has come. Little things that used to bring you joy are now worthless. Even the simplest tasks become painful. That is where you lack motivation now. Why would you keep on trying if nothing makes you happy anyway? All of this makes you feel even worse, and you get caught in a vicious circle. Suddenly you find yourself living in slow motion. Days become indistinguishable, just white noise, just heaviness filling your mind, spilling over your body. You feel as though you will never be happy again. You continue to back away and destroy relationships. You're ashamed for everything you've done and everything you haven't. There is a part of you that wants to make things right. A sudden positive upsurge makes you want to go out and meet people, but it's all very short-lived because you know it won't work anyway. Things that make your friends excited leave you indifferent, and you become aware of the huge gap that lies between you and other failure. It's not an option, so in the end you choose to be alone in your comfort zone where no one asks any questions. Low self-esteem and the lack of purpose become unbearable. You finally realize you can't go on that way, and two things can happen. You either decide to get some help, or you might attempt suicide.
Okay. All right. Now I want to show you guys this ECT treatment. Okay.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or who are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
Typically indicated for treatment-resistant psychiatric conditions. Most commonly mood disorders or depression, but there are multiple types of depressions that can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
When the patient's asleep, the stimulus is delivered, the seizure is monitored, they'll have just one seizure.
An electrical current is given to the brain, low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. Thanks to the anesthetic, it's very hard to tell. In fact, the only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens soon after and is monitored for a short while like any patient who has undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown for the WVU Health Report, I'm Dr. Ron Sullivan.
Pretty interesting, huh? That's a good question. I'm not really sure. I just know that it'll take most of the time. It's not a one and done kind of treatment. And most of the time it is not done for like a fix. It's more done to aid the medication in working. Like I said, medication is really the use for mood disorders. That is something they do have medications for. So yeah, I don't know how often they can do that. That's a good question. I think it would probably vary on the person that it was going through and how they were able to tolerate it. All right. We're going to do a crash course and an osmosis video because they're both really great summaries. They literally mention everything that we've talked about today. They fit perfect with lectures. Okay.
American psychologist and professor of psychiatry Kay Redfield Jamison is one of the world's foremost authorities on bipolar disorder. She's spent her career researching, lecturing, and writing seminal books on the condition, a condition that she also happens to have had her entire adult life. In her memoir, On Unquiet Mind, Jamison details what it really means to be bipolar. She writes of not sleeping for days on end, of feeling long periods of euphoria, and filling whole notebooks with her racing thoughts and grandiose ideas. While in these manic states, she experienced a tremendously inflated sense of self-esteem and did impulsive things that felt good at the time but had painful consequences, like going on lavish shopping sprees, engaging in promiscuous behavior, racking up credit card debt, and emptying her bank accounts. These episodes were followed by emotional crashes, crippling bouts of depression that sent her into a suicidal spiral. At the age of 28, Jamison tried to kill herself by taking an overdose of lithium, left into a coma, but thankfully emerged from it determined to find help through medication and therapy. Through her research at Writing, Dr. Jamison has pioneered our understanding of bipolar disorder, depression, and the nexus of mental struggles that we now think of as mood disorders. And she's probably one of the best ambassadors we have for all those people who live successful, productive lives with mental illness. Just like the anxiety disorders we talked about last time, mood disorders are misunderstood. They're diluted by depictions of depression as something that can be treated one day at a spa, or descriptions of people as manic depressive just because they were sad yesterday and aren't today. As students of psychology, our job is to understand what mood disorders really are, how they manifest themselves, and what might cause them. And as you probably guessed, this can be pretty tough terrain to explore. These disorders can take people from terrifying highs to pits of despair that seem all but bottomless. But in between, there's what Jamison has called a rich, imaginative life, all made possible by your moods. We're going to talk a lot about terms and concepts that mean something different than what you think they mean, but this time, the term mood is not one of those. In a psychological context, moods are pretty much exactly what you think they are. Emotional states that are even more subjective and harder to define than the emotions themselves. And while psychologists have defined about 10 basic emotions, moods tend to fall into two broadly and infinitely variable categories. You got the good moods and the bad moods. Probably the most important distinction between emotion and mood is that moods are long-term emotional states rather than discrete, fleeting feelings. And mood disorders, which are characterized by emotional extremes and challenges in regulating mood, tend to be longer-term disturbances. These include depressive disorders typified by prolonged hopelessness and lethargy, and bipolar disorders, the most prominent of which involve alternating between depression and mania. Depression has been called the common cold of psychological disorders, which is not to say that it isn't serious, but it's common and it's pervasive, and it's the top reason people seek out mental health help. We've all felt down before, obviously, often in response to a specific loss, a breakup or a lost job or the death of a loved one. And the fact is, you probably shouldn't feel bad at times like those. It can actually be good for a mind and body to slow down to help digest losses that you experience. But in general, sadness is temporary. And beyond the generally accepted social norms, or plunge into a depth that causes serious dysfunction that can find yourself in the territory of depressive disorders. The DSM-5, our handy and super flawed user's guide to psychological disorders, officially diagnoses a major depressive disorder when a patient has experienced at least 5 signs of depression for more than 2 weeks. These symptoms include not just depressed mood, but also significant weight or appetite loss or gain, too much or too little sleep, decreased interest in activities, feeling worthless, fatigued or lethargic, difficulty concentrating or making decisions, and recurrent thoughts of death or suicide. So while everyone experiences sadness, depression is a physiological as well as psychological illness. It messes with your sleep, appetite, energy, and neurotransmitter levels, all interfering with the way your body runs itself. Plus, in keeping with our definition of psychological disorders to be considered a true disorder, this behavior needs to cause the person or others around them prolonged distress, the feeling that something is really wrong. Just as a person with severe generalized anxiety disorder may never want to leave the house, A clinically depressed person often feels so hopeless and overwhelmed that they have trouble living a normal life. And unlike the bipolar disorders, the depressive disorders tend to be all lows. You've probably heard of manic depression. It's the outdated term for bipolar disorders. These include those classically dark lows of depression, but also facts of the opposite, of extreme mania in more severe cases. Someone suffering from a bipolar disorder may flip back and forth between normal and depressive and manic phases within a single day, week, or month. And a true manic episode doesn't just mean being energetic or happy. It's a period of intense, restless, but often optimistic hyperactivity in which your estimation of yourself and your abilities and your ideas can often get skewed, like really skewed. Some patients experience mania only rarely, but when they do, it can be destructive. Kay Jameson has testified to that. Once during a manic episode, she bought up a drugstore's entire supply of snakebite kits, convinced of an imminent attack of rattlesnakes that only she knew was coming. In another, she purchased 20 books by the Penguin Publishing House because, she said, it could be nice if the penguins could form a colony. In other words, bad judgment is common, and it can get worse. Full-blown manic episodes often end up in psychiatric hospitalization since the risk to self or others can become severe. When the highs eventually end, they're often followed by dark periods of depression. When left untreated, suicide or suicide attempts are common, another element of the disorder that Jameson herself can attest to. Like so many things in psychology, the cause of mood disorders is often a combination of biological, genetic, psychological, and environmental factors. We know, for example, that mood disorders run in families. Genes matter, and you're more likely to experience a bipolar or depressive disorder if you have parents or siblings who suffer from them. Studies of identical twins show that if one twin has a bipolar disorder, that the other has a 7 in 10 chance of also being diagnosed, regardless of whether they were raised together or apart. And while a stressful life can't give you bipolar disorder, it could trigger a manic or depressive episode in someone with a pre-existing condition, or start to descend into a major depressive episode in someone who never before experienced depression. In other words, a person who loses a loved one could go from sad to depressed or slide into a bipolar episode, but it couldn't cause them to have the disorder to begin with. In the case of depressive disorders, for most people, after weeks, months, or even years, their depression can end, hopefully, with a return to baseline healthy functioning. Worldwide, women tend to be diagnosed with major depression more often than men, but many psychologists think this is simply because women tend to seek treatment more. It's also possible that depression in men tends to manifest itself more in terms of anger and aggression than as sadness and hopelessness. This is just an example of how depression is much more than just being sad, and that the characteristic lack of purpose and hopelessness can manifest itself in a lot of different ways. Looking at mood disorders from a neurological perspective, we see that depressed, manic, and average brains show very different brain activity in neuroimaging scans. As you might expect, the brain in a depressed state slows down, while a brain in a manic state shows a lot of increased activity, making it hard for that person to calm down, focus, or sleep. Our brain's neurotransmitter chemistry also changes with these different states. For example, norepinephrine, which usually increases arousal and focus, is severely lacking in depressed brains, but kind of off the charts during manic episodes. In fact, drugs that seek to reduce mania in part do it by reducing norepinephrine levels. You may have also heard about how low serotonin levels correlate with depressive states. Exercise, like jogging or breakdancing or whatever, increases serotonin levels, which is one reason exercise is often recommended to combat depression. And most medications designed to treat depression seek to work by raising serotonin or norepinephrine levels. And of course, there's yet another way to look at things. The social cognitive perspective examines how our thinking and behavior influence depression. People with depression often view bad events through an internal lens or mindset that influences how they're interpreted. And how you explain events to yourself in a negative or positive way can really affect how you recover from them. Or don't. Say you were humiliated in the lunchroom when someone tripped you and your chicken soup flew all over the place, and you sat down on a brownie and it was a bad day. A depressive mind might immediately start thinking that the humiliation will last forever, that no one will ever let you live it down, that it's somehow your own fault, and you can't ever do anything right. That negative thinking, learned helplessness, self-blame, and overthinking can feed off itself and basically smother the joy out of the brain, eventually creating a vicious, self-fulfilling cycle of negative thinking. The good news is that cycle can be broken by getting help from a professional, turning your attention outward, doing more fun things, maybe even moving to a different environment. But again, that social cognitive perspective is just part of a much bigger puzzle. Positive thinking is important, but it's often inadequate on its own when up against genetic or neurological factors. So mood disorders are complicated conditions, and rarely are they eliminated with a single cure. Instead, they're often things you just live with. And as Dr. Jameson has shown us, you can live well. Today, we talk about what mood disorders
Pretty much matched perfect, right? This one's going to break down the more the postpartum, atypical, melancholic, persistent that we talked about there.
Probably come out of a particularly sad movie and said something like, man, that was depressing. In this case, you're talking about how, at that moment, the movie made you feel sad, discouraged, hopeless, or anxious. You probably wouldn't say something like, man, that movie was clinically depressing. The latter expression refers to a much different state of depression. Clinical depression, which is sometimes called major depressive disorder or unipolar depression, is a serious mental disorder that has a lifetime incidence of up to 20% in women and 12% in men, making it one of the most common reasons people seek out mental health services. That being said, as well as being relatively common, clinical depression is, in fact, very serious. It's so serious that it interferes with someone's day-to-day life, like working, studying, eating, and sleeping, essentially leading to this overall feeling that life isn't enjoyable. But what causes someone to feel this way? Well, we don't exactly know what specifically causes clinical depression, especially since it can be so different between patients. It's probably a combination of factors, though, like genetic factors, biological factors, environmental factors, and psychological factors. It's been shown that people with family members who have depression are 3 times more likely to have it themselves. And this link seems to increase with how closely related family members are. Biologically, though, most medications focus specifically on neurotransmitters. Neurotransmitters are signaling molecules in the brain that are released by one neuron and received by receptors of another neuron. When that happens, essentially a message is relayed from one neuron to the next. Regulation of how many of these neurotransmitters are being sent between neurons at any given time is thought to play a super important role in the development of symptoms of depression, since they're likely involved in regulating a lot of brain functions like mood, attention, sleep, appetite, and cognition. The 3 main neurotransmitters that we focus on for depression are serotonin, norepinephrine, and dopamine. Why do we focus on these 3? Well, because medications that cause there to be more of these neurotransmitters in the synaptic cleft, this space between the neurons, are shown to be effective antidepressants. And this finding led researchers to develop the monoamine deficiency theory, which says that the underlying basis of depression is low levels of serotonin, norepinephrine, or dopamine, which are all called monoamines because they have one amine group. Additionally, it's thought that each of these might have an impact on certain sets of symptoms with depression, like norepinephrine on anxiety or attention, or serotonin on obsessions and compulsions, or dopamine on attention, motivation, and pleasure. So if one of these is down, then that could lead to a set of specific symptoms being felt by the patient. Serotonin in particular is thought to be a major player. Some theories suggest that it's even capable of regulating the other neurotransmitter systems. Although evidence supporting this theory is still pretty limited. Some hard evidence implicating serotonin in depression has to do with tryptophan depletion, which is the amino acid the body uses to make serotonin. So if you take it away, you can't make as much serotonin. And it's been shown that when the body can't make as much serotonin, patients start getting symptoms of depression. So that's all well and good, but unfortunately, the reasons why serotonin or other neurotransmitters might be lost or decreased in depressed patients in the first place isn't well known, and research remains ongoing. Ultimately, development of depression is complicated, right? It involves these biological components in combination with the genetic components as well as environmental factors, which can be specific events like a death or a loss, or sexual and physical abuse. In order to diagnose clinical depression, patients must meet certain criteria that are outlined in the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition. First, they must be affected by at least 5 of the following 9 symptoms most of the day, nearly every day. Depressed mood, diminished interest or pleasure in activities, significant weight loss or gain, inability to sleep or oversleeping, psychomotor agitation, like pacing or wringing one's hands, or psychomotor impairment, like this overall slowing of thought and movements, fatigue, feelings of worthlessness or guilt, lowered ability to think or concentrate, and finally, recurrent thoughts of death or suicidality, including suicidal thoughts with or without a specific plan, as well as suicide attempts. And these symptoms must cause significant distress to the patient's daily life. Also, the depressive episode can't be due to a substance or other medical condition. The symptoms can be better explained by another mental disorder like schizoaffective disorder. And finally, the patient can have had a manic or hypomanic episode at any point. Additionally, sometimes major depressive disorder can be divided into subtypes, or closely related conditions. Postpartum depression is a subtype that can happen following childbirth. Although studies have shown that in many cases, onset of depression occurs prior to childbirth as well. So it's now diagnosed as depressive disorder with peripartum onset. In other words, the onset happens during pregnancy or 4 weeks following delivery. It's not quite understood why this happens, although hormonal changes likely play a role, especially estrogen and progesterone. Also, though, an abrupt change in lifestyle might be an important causal factor, especially because this can happen in men as well as women. Atypical depression is another important subtype that's characterized by an improved mood when exposed to pleasurable or positive events, called mood reactivity. And this is in contrast to other subtypes like melancholic depression, even during what used to be pleasurable events. Also, atypical depression often includes symptoms like weight gain or increased appetite, oversleeping, heavy feeling limbs, also known as leaden paralysis, and rejection sensitivity, essentially feeling anxiety at the slightest evidence of rejection. Finally, dysthymia, now known as persistent depressive disorder, is sometimes used to describe milder symptoms of depression that happen over longer periods of time, specifically 2 or more years with 2 or more of the following symptoms: a change in appetite, a change in sleep, fatigue or low energy, reduced self-esteem, decreased concentration or difficulty making decisions, and feelings of hopelessness or pessimism. Knowing that so many factors are probably involved in depression, it can be a challenge to treat. Although with the right treatment, 70 to 80% of patients with clinical depression can significantly reduce their symptoms. Treatment can come in many forms and are most commonly grouped into 1 of 2 major categories. 1, non-pharmacologic approaches, in other words, things other than medications. And 2, pharmacologic approaches, either a single medication or combinations of medications. Starting with the non-medication approach, a number of studies have shown the benefits of physical activity in helping with depression. There are various reasons why it's thought to work, ranging from the release of neurotransmitters, endorphins, and endocannabinoids, to raising the body temperature and relaxing tense muscles. Regardless of the exact mechanisms, data suggests that exercising for 20 minutes 3 times a week can help alleviate depression symptoms. There's also a lot of research exploring the relationship between diet and depression. And although there are no silver bullet foods, many experts suggest healthy eating habits like more fruits and veggies. Beyond physical activity and healthy eating, which is more helpful for a number of reasons, another major non-pharmacologic approach is psychotherapy, or talk therapy, which is definitely preferred for young patients and for those with milder symptoms. There are a few popular approaches, including cognitive behavior therapy and interpersonal therapy. And the most important thing here is that these approaches depend heavily on the relationship between the patient and the therapist, as well as the clinical skills of the therapist. If patients have more severe depression or mild depression for a longer period of time, then antidepressant medication might be prescribed along with the therapy. The most commonly prescribed medications are selective serotonin reuptake inhibitors, or SSRIs. In the synaptic cleft, after neurotransmitters get released, those neurotransmitters are normally reabsorbed. SSRIs block the reabsorption or inhibit the reuptake of serotonin, which means that there's going to be more serotonin in the synaptic cleft. Other classes of antidepressants that are less commonly prescribed are monoamine oxidase inhibitors, or MAOIs, and tricyclics. As a final last-line treatment for severe depression, ECT might be performed under written consent. ECT stands for electroconvulsive therapy, and is when a small and controlled amount of electric current is passed through the brain while patients are under general anesthesia, and this induces a brief seizure. Although ECT has been used for decades and actually does seem to be effective for about 50% of patients, the reason why electrically induced seizures seem to improve symptoms is not well understood. All right, clinical depression is tough, right? And for those trying to help treat it. Unlike many other illnesses, depression depression carries with it a lot of social stigma and can lead to moral judgments that can make a person with depression feel even worse. Love and support from friends and family helps tremendously, and having a strong social support network has been proven to lead to better outcomes. Thanks for watching. You can help support.
All right. One more. I wanted to show you about some occupational therapy treatment with depression. You guys ever watch OT Dude on YouTube? He's a pretty good resource that when you start studying for exams and stuff, like when you start studying for your board exams, he's a good one. There's a few more to OT Miri. Has anybody heard of her? She's this Asian lady who has these cheeks that are just massive. Everyone knows her by her cheeks, but her name's OT Miri. She's super smart. She has a lot of good study tools. That's somebody else to keep in mind when you're thinking about studying for exams. Like you can look up specific things that you may be having trouble with, range of motion, manual muscle testing, whatever, that we're doing, and she will break it down way better or in a different way than what Professor Trilly and I will. She's a good resource. A lot of people really like her.
A Dropbox family plan gives you and your 5 loved ones your very own Dropbox account to store memories from the past.
Hey OT dudes and dudettes, in this video we'll be talking about psychosocial pharmacology. There's a lot of information to cover, so let's get right to it and let's get focused. Medications for depression. We'll start with SSRIs. SSRIs stands for selective serotonin reuptake inhibitors and are the most commonly prescribed antidepressants. Doctors often start by prescribing these SSRIs. They can help with symptoms of moderate to severe depression. Compared to other classes of medications, SSRIs are considered to be generally more safe. Let's go over the pharmacology of SSRIs. SSRIs increase the levels of serotonin in the brain by blocking the reuptake in your brain. Serotonin is the key hormone that stabilizes our mood, feelings of well-being and happiness. SSRIs may also treat anxiety disorders as well. Common medications that are approved include Prozac, Zoloft, Paxil, Celexa, and Lexapro.
Those look a little more familiar. You probably heard a lot of those, right?
Diarrhea, headache, drowsiness, dry mouth, insomnia, nervousness, dizziness, sexual dysfunction, weight loss or weight gain, and other safety concerns such as for Celexa include arrhythmias in high doses, drug interactions. Serotonin syndrome is when high levels of serotonin accumulate, often due to another medication. Signs and symptoms include anxiety, agitation, fever, diaphoresis or sweating, confusion, tremors, discoordination, changes in blood pressure, and tachycardia. Possible risks for pregnancy and breastfeeding also exist. There's also a black box warning, which basically states that there is possible suicide ideation for those under age 25. Let's talk about SNRIs. SNRIs stand for serotonin and norepinephrine reuptake inhibitors. They are a class of antidepressants that also help to relieve depression symptoms. SNRIs have also been used for anxiety and chronic nerve pain. Let's go over the pharmacology of SNRIs. SNRIs block the reuptake of serotonin and norepinephrine in the brain. The changes in brain chemistry help to regulate mood and relieve symptoms of depression. Common medications include Prestige, Cymbalta, Effexor, and Benzema. Side effects are very similar to SSRIs, include nausea, dry mouth, dizziness, headache, diaphoresis or sweating, fatigue, constipation, insomnia, sexual dysfunction, and loss of appetite. Let's go over now some of the safety concerns. It may cause hypertension, may worsen liver problems. There are drug interactions when combined with certain medications, such as herbal products, that may increase the risk of bleeding. There is serotonin syndrome, possible risk for pregnancy and breastfeeding. The black box warning, which is the increased suicide ideation for those under age 25. And the black box basically exists for all of these antidepressants that we'll talk about. Atypical antidepressants. Atypical, like the word and how it sounds, are less common, and they're
considered another class of antidepressants. They also do not fit into the classes of SSRI or SNRI. Atypical antidepressants also work differently from one another to help manage depression. Let's go over the pharmacology. Just like other classes of antidepressants that we talked about, atypicals alter levels of neurotransmitter in the brain to help regulate mood and relieve symptoms of depression. Atypical antidepressants may change levels of dopamine, serotonin, or norepinephrine. Common medications include Wellbutrin, Remeron, Trazodone, Surzone, Vibrid, Trintellix, and a newer one, which is a nasal spray called Spravato. Side effects are very similar to the ones we talked about earlier, include nausea, dry mouth, dizziness, lightheadedness, drowsiness or insomnia, constipation, diarrhea, changes in appetite, and sexual dysfunction. Let's go over some safety concerns with atypicals. They should not be used for those with seizures or an eating disorder. They may increase cholesterol, weight gain, there is related liver failure, and priapism, which is a permanent and a painful erection, arrhythmias, increased bleeding, drowsiness, such as when driving, and drug interactions combined with other medications, such as herbal products, that may increase the risk of bleeding. There's also the serotonin syndrome again, the risk for pregnancy and breastfeeding, which you should consult with the doctor, and the black box warning that we mentioned earlier. Now let's talk about tricyclic antidepressants. Tricyclics are the most well known, but they're also tetracyclics, which mean 4-ring, and they're a class of antidepressants called cyclic antidepressants. Although they are effective, they are less commonly used than the other ones mentioned earlier. They may be a good option if the other options are ineffective. Let's go over the pharmacology. Cyclic antidepressants block the reabsorption of serotonin and norepinephrine to increase the levels in the brain. It has also been used, by the way, to treat OCD, anxiety, and nerve pain. Let's go over the common medications for cyclics. There are, I'm going to probably mess up a lot of these names, amitriptyline, amoxapine, norepinephrine, doxepin, tofranil, Pamelor, protriptyline, and trimipramine. Side effects include drowsiness, blurred vision, constipation, dry mouth, a drop in blood pressure when moving from sitting to standing, which can cause lightheadedness, urine retention, weight loss, increased appetite leading to weight gain, excessive sweating, tremors, sexual problems, and other safety concerns. Let's go over these. There's confusion, irregular heart rate, seizures, drug interactions, serotonin syndrome, complications of chronic health conditions, possible risk for pregnancy and breastfeeding, and black box warning. So these basically are a little bit more serious than the ones that we mentioned even earlier. Let's go over monoamine oxidase inhibitors, or MAOIs, sometimes called MAOs. MAOs were the first class of antidepressants that were developed. So they have more side effects than the other classes of antidepressants that we mentioned. Being on MAOIs requires diet restrictions and awareness of other side effects with other medications due to the basically potential for a very high blood pressure to build up. So let's go over the pharmacology. MAOIs prevent the enzyme monoamine oxidase from removing the neurotransmitters norepinephrine, serotonin, and dopamine from the brain. It may also affect other neurotransmitters and also the digestive tract system as a side effect. MAOIs are generally not prescribed for children. It has also been used, interestingly, for Parkinson's disease. Let's go over the common medications: Marplan, Nardil, Amsan, Parnate, and a skin patch version called Celagenine. Side effects include dry mouth, nausea, diarrhea or constipation, headache, drowsiness, insomnia, dizziness, or lightheadedness, a skin reaction if you're using the patch, involuntary muscle jerks, low blood pressure, reduced sexual desire or difficulty reaching orgasm, weight gain, and difficulty starting a urine flow. There's also muscle cramps, prickling or tingling sensation of the skin or paresthesia, safety and dietary restrictions, possible risk of pregnancy, and of course, the black box warning. So what foods or diet should you be on and what things you should avoid. These include aged cheeses, sauerkraut, cured meats, draft beer, and fermented soy products such as soy sauce or tofu. There are possible interactions with other drugs too, such as other antidepressants, pain relieving drugs, allergy medications, herbal supplements, things like that too. So be careful of that. There's also the black box warning as well. Last, we're going to go over other medications. Doctors may combine two antidepressants or combine an antidepressant with another medication to enhance the antidepressant effect. The same side effects would generally apply, probably even more because you're using two or more. So consider that as well for the safety. That pretty much sums up the overall picture of these psychosocial medications. There's of course many more, but these are the most common ones. I recommend maybe putting these down on a flashcard or finding another way to memorize these and basically regurgitate the information. You've probably heard of some of these names before, so you don't have to memorize all of them. One to definitely pay attention to are the MAOs and the dietary restrictions and the side effects, and knowing basically what's more serious and what's less serious in terms of side effects and what's more.
Okay, so with all that being said, we're not pharmacists, right? Why do we care about the medications with these? Why does occupational therapy have anything to do with this? It can affect the way they perform. You need to know these side effects. You need to be familiar with the medications that your patients are on, because if you're having a patient who's going through and having one of these bad side effects, it could very well be the cause of a medication, and then that needs to be reported to their doctor, to, whoever is prescribing this medication. Listen, they're having, they weren't having suicidal thoughts. Now they are having suicidal thoughts, and they have a lot of weight gain or weight loss or whichever. So it's really important to keep in mind your side effects for each one of these medications. Okay. That's just going to help you with practice. I'm not going to go through and test you guys on all the medications. There are medication questions on the exam from this chapter, but nothing, if you read the chapter and you listen to the lecture, you should get them. Okay. All right. Let me